Hello, and welcome to episode 17 of Public Interest Podcast with your host, Jordan Cooper, where we interview politicians, activists, advocates, and others who improve the state of the world. Today, we're here with Justin Wasserman, who is a pain management physician. How are you doing today, Justin?
I'm doing great, Jordan. Thanks for asking.
Awesome.
Great to be
So,
here.
the first question that I'd like to ask you today is, what are you currently doing, or what have you ever done to advance the state of the public interest, and why?
Well, I'll tell you, I give a fair amount of public speaking in my own capacity as a pain management specialist, which I think has clearly been a big issue in today's world. All of us see, as I was saying earlier, this tremendous, I should say horrendous is a better word for an opioid epidemic that has just ravished communities throughout this country. And it obviously heavy ties into the whole issue of pain management, all right? A lot of it, really probably all of it, if you will, started from the whole standpoint of how we treat chronic pain in this country. And it all stemmed from that. Now we're seeing this huge explosion of heroin epidemic issues throughout the country, which again started from this whole pain management problem. So what I've been doing in my capacity is trying to educate other physicians, people in the community and so forth, on how this started and how we can go forward to diminish this problem and how we can potentially put an end to it as the ultimate goal.
How did you decide, you went to medical school, you're entering residency, what is it about pain management in particular that attracted you to this area, this specialty within medicine?
In my particular case, I had a memory from when I was 13 years old and I had my appendix removed, which is that I remember my pain was not well treated. I was in the hospital, I was, again, about 13 years old. I remember distinctly how severe the pain was from it was obviously a quite simple operation, and how it was just a horrible pain that stuck with me for many, many, many years. From that standpoint, I guess my background in biological sciences, my background in chemistry, my love of the human body in general, learning about the human body, led me to pain. When you're dealing with pain, you really are kind of a jack of all trades. You're part orthopedic. You're a big part psychiatrist in some senses, and what I do for sure, I'm probably more psychiatrist than I am orthopedic, but of course you have to have a great understanding of the anatomy, the human body, the musculoskeletal system. As you know, much of the chronic pain that we treat, by no means all, but much of it, can often stem from musculoskeletal issues like low back pain, knee injuries, hip injuries, arthritis, and so forth. So you have to have that knowledge, but at the same time, when chronic pain becomes just that, chronic, it requires a whole separate set of skills which really delves into the realm of psychiatry, psychology, human behavior, learning how to live with pain, what we call in our treatment field, teaching patients utilizing techniques called cognitive behavioral therapy in order to treat their pain. So in that sense, you really do become a jack of all trades. Because the pain can affect so many different systems within the body, you have to understand that the gynecological system. I deal with a type of pain called vulvodynia, which is a very specialized type of pain that tragically afflicts someone where they get a very unusual type of vaginal pain, or in other cases bladder region pain, which is sort of unexplainable. We don't quite understand how it works. So you have to have a good knowledge of that system of the body. So again, you deal with all aspects of the human body, and you get to borrow from many different teachings within the medical field. So for me, it was attractive.
So in the human experience, there are many different types of pain, and physical just speaks to one aspect of the realm of pain. Obviously, there's emotional pain for any one of our listeners who's ever been through an emotional breakup with a romantic partner, anyone who's experienced the loss of a loved one. Physically, your body hasn't really changed just because a loved one has died or broken up with you. But on the other hand, there are physical symptoms of pain associated with an emotional event. Can you speak about really what pain is and how you treat, the many different types of pain, from emotional pain to physical pain, and what that says about how that informs your practice?
Well, Jordan, that's an excellent question, and quite frankly, I don't think anyone could have asked it better. It's an issue that I would argue is probably going to the crux of why pain is so misunderstood and can actually be tied into the opioid epidemic, because all pain has an emotional element to it. Remember, there are some people out there that actually do things in life that inflict a great deal of pain, but they don't always manifest it as such an unpleasant experience. People who climb mountains at extreme heights, which is obviously an extremely painful thing to do. You have to use every last bit of strength you have in your body to make that last bound, that last climb. You know, they're inflicting tremendous amount of pain, but they get tremendous joy out of it. There's a huge emotional element to it. And the way that pain manifests is heavily dictated on the emotional state of how a patient feels. I'll give you an example. If someone is at war, this has been well studied, well documented. If someone is in the midst of a battle, there have been many cases, and soldiers will tell you, where they can even get shot. They can even have a gaping wound bleeding from what would otherwise be an extremely painful phenomenon. But because they're so focused on the battle at hand, they're so focused on protecting their buddies, their comrades, and themselves, that they may not even think about it. And then someone may look at them and say, you know, this is terrible, you have a huge wound. And then when they notice and they get the wound stemmed in the field, they get back to the barracks, they may then start feeling what becomes the physical manifestation of pain. But because they are so emotionally fixated on that battle at hand, they may not even perceive it as much. A little analogy I always make with patients to try to explain this, because a lot of people don't understand that. Even a lot of doctors don't understand that, as I mentioned earlier. I give this little analogy where you have an individual that walks into a tavern, a bar, if you will, and he walks in there and he just found out something very terrible happened. He found out there was a tragic death in the family. He walks in that tavern and some belligerent, drunken person decides to attack this person, hits this person. It's a very painful phenomenon. The person who gets hit perceives it as very painful. Already the person's in a very bad emotional state. Something very bad happened, and it's almost like that physical attack was just adding insult to injury. That person's had a bad day, to say the least. Now let's take a flip scenario. Someone just found out they won the Powerball lottery. They just found that their entire life, every way that they view their life, is radically changed. Now they walk into that same tavern. They still get hit. They're in incredible joy. They're celebrating with friends. They get hit. That individual likely will not feel even the physical manifestations of that physical assault the way that the first scenario would. So again, very much one's emotional state very much dictates the way that one manifests even physical pain, where it relates more in a more real-life scenario in a clinic like mine, where I deal with very severe intractable pain. And just to, for a second, give a background about my clinic, what I do is I deal with extraordinarily severe, if you want to call them end-stage chronic pain patients. In fact, the majority of my patients get referred to me actually from other pain doctors. So pain doctors themselves get kind of a, I don't want to call it a reject group of patients, because they get patients from primary doctors where they simply run out of things to do. But I'm getting the ones that they can't handle. So I deal with a very unique population of patients. But what I can tell you with the patients that I see is there's a tremendous amount of psychopathology diagnosed in these patients. Depression, anxiety, manic depressive / bipolar disorder, even schizophrenia, primarily depressive anxiety disorders, many of which, interestingly enough, predated the pain. And that's key to note, they predated the pain. What my point in highlighting that out is that what we're finding now, to sort of tie this whole thing together in terms of your original question, emotional pain, physical pain, is that many of the same centers within the brain that regulate mood, that actually dictate if one develops certain psychiatric diagnoses also overlap with the parts of the brain that actually make us manifest pain. They're tied together. And so hence, if one does have depression, if one does have anxiety, even if early in their life, and it long predated a chronic pain condition, those individuals have a higher rate of developing various chronic pain states later in life, even if it's not something genetic or physical. An example, that studies have shown in recent years that patients who have histories of sexual abuse, physical abuse, even just emotional abuse, have a higher rate of developing chronic pain states later on in life. Now, where the one thing I want to mention in relation to that is where it may tie into opioids is that unfortunately these same risk factors that often lead, or at least I should say, I don't want to say lead, but increase the risk of developing chronic pain, such as depression, anxiety, sexual abuse, those sort of things, are also tremendous risk factors for the development of opioid addiction, which again is probably one of the biggest reasons why we see this huge problem having come out of the pain management model in this country from certainly the mid to late 90s and the early 2000s and even the mid 2000s, where doctors were much more readily willing to prescribe opioids, often in very high dosages, to patients. Why is that important? It's important because remember what I said, those same factors that would lead somebody to get chronic pain in the first place are also the same factors that often lead one to develop substance abuse disorders later in life.
Interesting. So there are individuals who are getting swept up in an opioid epidemic because are they self-medicating or are they getting prescription medications from their physician, or are they beginning with prescription medications as kind of a gateway and then they're just ever increasing the dosage?
Well, Jordan, that's another great question. And the answer to that is actually both. It's both. All right, there's a tremendous percentage, at least certainly in the early stages of the heroin epidemic, a majority of patients who actually started out getting prescribed pain medications or often obtaining them illegally. They stole them from parents, they stole them from a family member who had them in the medicine cabinet, where the prescriptions were actually given for pain, but it eventually developed into an addiction, and then when they got cut off or they lost their supply of those prescription opioids, they then turned to heroin because it was a cheap, readily available source of that. All right? And so, again, it often started out with pain, where they initially used them for pain, often, in fact, for self-medication. I happen to also treat addiction as well, and I'm certified by the U.S. government to prescribe a drug called buprenorphine for the treatment of opioid abuse disorder. You have to have a special certification to do that, which I have. And I can tell you, and I spend a lot of time with the patients that I see, and when talking with the patients that I see who have addiction disorders, of which, by the way, many of them started out, many of them, if not the majority of the ones that I see, that have chronic pain. In fact, they still have chronic pain. They have, think about that, they have addiction. They clearly meet the criteria for addiction, but they also have legitimate, bona fide chronic pain. It's not that one went away when the other occurred. They both occur often comorbidly. And these individuals will often tell you that when they started misusing the opioids, that they were in fact self-medicating these mental health disorders, as you alluded to. And we find that same phenomenon in alcoholism as well, where patients will often use alcoholism to self-medicate anxiety, depression, having, just very bad times in life. They go through divorce, they lose their job, their life collapses around them, and they see alcohol as being a temporary escape for them. They develop an addiction to it. The same thing happens with pain medication, but in some ways it's even more insidious with pain medication. Why do I say insidious? Because it's legitimized in the patient's mind by the fact that it's being prescribed by a doctor. Here we are in society where doctors are in some ways this revered group of people. They're here to help people. They're here to spread good health amongst people and to treat people. And certainly with the Hippocratic Oath, rule number one is to do no harm. Well,
and for our listeners, the Hippocratic Oath is what?
Part of one of the first, if not the first law of the Hippocratic Oath, number one, is to do no harm. So patients think, well, gosh.
And it's something that medical students say in medical school or in residency. Who says the Hippocratic Oath?
You're supposed to say the Hippocratic Oath. Often, sometimes now in medical schools, I know in my medical school at some point they initiated a new it wasn't there when I came, but it's my understanding of my medical school, which was University of Cincinnati, they initiated something called the white coat ceremony, where they sort of give that first white coat to incoming medical students. And I think that they even have those students administer the Hippocratic Oath. And certainly when you get your degree, you're supposed to recite your Hippocratic Oath.
So every physician in the United States has sworn this oath to do no harm.
That is correct. And so think about it from a patient standpoint. The patient who's given what seems like a very innocuous prescription for an opioid, a narcotic, that is, thinks, well, of course this isn't a problem. The doctor can't do any harm. He or she's the doctor, right? So I can take this. So in some ways the patients take that medication, they feel better both physically and emotionally, and because it comes from a doctor and it's legitimized by the medical profession, it somehow gives them the green light that this is okay, that this is fine.
I want to talk a little bit about both addiction and pain. These are terms that are thrown around in society. People will say, oh, I'm addicted to exercise. Oh, I'm addicted to coffee. Oh, I'm addicted to fast cars. Or, oh, gosh, I waited in line for so long, it was really painful for me. Or I went through that test and that was painful. There's just such a range of addiction and of pain. And some of it is emotional, and some of it is physical, some of it is innocuous, and some of it is dangerous. I guess I'm wondering and then I'm thinking most of it resides in your brain. So I guess I'm trying to think, what is really the connection between, what is real addiction? Let's start with that.
All right, Jordan, I'll tell you, addiction is a very much misunderstood terminology. And it's misunderstood because it's not 100% clear, even within the medical system, if you will, even within medical science, of exactly what constitutes addiction. There are certain phenomena, nonetheless, that are common throughout any of these addictions, even though all the ones you refer to that aren't necessarily of substances, if you will, but rather behaviors that seem to have in common. I think the primary, most important factor that constitutes addiction pathology, if you will, is the fact that whatever that person compulsively does, it gives them a sense of reward. Now, when I say reward, there actually is a part of the brain that actually appears to be responsible for administering that reward. In the human brain, that part is called the nucleus accumbens. And it appears that many of these different behaviors, again, whether it's using a substance like an opioid, alcohol, or whether it becomes a gambling addiction, a sex addiction, the individual gets some sense of reward that gives them a short period of time of great pleasure, euphoria, if you will, and then that reward goes away, and they develop at some point a compulsion without control to keep trying to obtain that reward over and over and over, despite the fact that continuing to obtain that reward can cause great harm within their life, their families, and their entire existence. That's a key. It's pathology because
there has
their
to be
lives
harm.
Are affected, are harmed in some way, themselves and those around them, because of their compulsion to keep seeking that reward over and over, often beyond their control.
So to differentiate between addiction and other behaviors that humans do regularly, for instance, I routinely go to work Monday through Friday, 9 to 5, and I get rewarded with my paycheck every other week. Or I routinely breathe, and I routinely eat and drink water and go to the bathroom and sleep. Every single day I do these things. But there's not a harmful consequence to those things. There's not a harmful consequence in my opinion, to going to work every day throughout the week. So therefore, it's not an addiction, because even though it's a pattern of behavior that's continued and perpetuated throughout time, one, it's necessary for survival, the physical things I mentioned, and then the work, it's more peripherally necessary for survival, but it's not negative. And is that the way you differentiate between patterns of behavior that we all do and patterns of behavior that are classified as addictions?
I would say that is the question you ask, I'd say that is the primary aspect that differentiates it. Another big difference, Jordan, is some of those behaviors that you talked about are not necessarily compulsive. In other words, you mentioned, I go to sleep every night. Well, we get tired, we go to sleep. But if there was some magic switch that someone could actually trigger off, and you didn't feel tired anymore, and you felt actually quite alert, hypothetically, you may not even really want to sleep. You sleep because it's a physiological necessity. Your body needs it. It doesn't necessarily crave it. It needs it because your body simply wears down. What happens in addiction is they actually develop pathological cravings for the behavior.
And
So even when
pathological.
they don't need it. In other words, these individuals that develop addictions to painkillers every day, that we read about every day in the paper,
Yeah.
where people are dying in droves, which now become the #1 cause of accidental death in the United States of America, even surpassing automobile wrecks, which is dying from opioids. It's a shocking statistic, but it's very true. That behavior is not a necessity. One doesn't need that opioid. They do it because they crave it and they desire it. And the cravings can become so intense that, as I alluded to earlier, even if they know that these cravings are so harmful and that the behavior is so bad for their body and so bad for their psychosocial, physical, mental, emotional, familial function, in other words, every aspect of their existence, they still can't resist doing it. I mean, I think about the numbers of patients that I've treated over the years that heard their whole entire careers, everything they worked for, have been utterly destroyed just to obtain the high, the euphoria they get from that substance is mind-boggling. I'm talking about physicians, surgeons I've treated,
what if
government attorney. I treated a government attorney who gave up everything, who was forging radiology reports to make it look like he still had cancer to somehow justify the usage of opioids so he could scam doctors on getting opioids. These are shocking
So imagine
things.
I had infinite money. I was a huge billionaire. And I'm able to afford as much heroin as I want. And I'm a heroin addict. Why is this addiction so bad? It seems like you told me it's bad because you start destroying relationships, destroying your own career, destroying a lot of things in order to get money to buy the drug. But if you had infinite money and infinite access to this drug, why is addiction to heroin a bad thing?
Good question. Again, addiction to anything is a bad thing because when this compulsion takes over, what happens is the person spends an inordinate amount of time. It's not just monetary resources. It's also their thinking, their focus. Everything revolves around that next fix. And what happens is that next fix starts becoming greater and greater in dosage. They develop tolerances to the drugs that they abuse often, where they often keep needing more and more and more. When that happens, you then start crossing a Rubicon where the dosage becomes extremely dangerous and it can actually cause death. Remember, these medications, opioids in particular, and even alcohol, there's a very fine line between doing enough to make you high, if you will, euphoric, and enough to make you dead. It's a very fine line. In medicine, we call that a very, if you will, therapeutic window, a narrow therapeutic window. So if I'm prescribing an opioid for pain, and someone, say, has cancer, it's very severe pain, so maybe I have to use a bit higher dose. One has to be extraordinarily cautious to use enough medication to adequately treat the pain, but not enough to cross that thin line to where it suppresses their breathing capacity and they can die. What also happens is it's not just a question of
They
whether
suffocate?
They suffocate. The way that one dies from opioids is they simply stop breathing. That is how one dies of an opioid overdose. When you read these cases where people tragically
Like their muscles
die,
are so relaxed they can't even.
it's not that
cause.
their muscles do get relaxed as a consequence of the drug, but it's actually that the drug itself suppresses the breathing center within the central nervous system.
Okay.
It actually suppresses the breathing center. There's a part of your brain within the brain stem that actually gives you the drive to breathe.
And it suppresses
and opioids
that.
actually suppresses that part of the brain.
Wow.
So what often happens with patients anyone, patients or non-patients, who die of an opioid overdose is they simply go to sleep. It causes profound sedation. While they're in that very suppressed sleep state, they simply stop breathing. All right, so that's a common way, that mode of which they die. Number two, you asked about consequences. Again, these patients get compulsed to use these drugs. They're not thinking about life. They're not trying to be great mothers and great fathers and great parents and great husbands and great wives. They're not thinking about that. They're thinking about, where do I get into my next fix? Also, keep in mind, when someone's in that state, they're not functioning at full capacity. These drugs, when they're euphoric, when they cause that amount of high that they want, they can cause tremendous cognitive diminishment. They're not thinking at full capacity. It's very hard to be in a boardroom for a top corporation. You mentioned the billionaire individual who has unlimited financial resources. They're not going to function at a high level state where they're in a boardroom and they're nodding off at their desk. Often, when I first start treating patients who come to me with the disease of addiction and they're still in that state, you'll see in my waiting room half passed out. And it's sometimes hard to even get a history from that. Clearly, that's not a functional state. So what happens is individuals, just like you hear about with alcoholics, alcohol is not expensive. Even your average person, someone who has a meager wage, can afford unlimited amounts of alcohol. But obviously, when someone's an alcoholic, they lose jobs. They go to the corporate party at Christmas time, and they make a fool out of themselves. And people know, oh, God, that's so-and-so, that's the drunk person. And then they start showing up late at work and having absenteeism. And because they're hungover, they call in sick every day. And they lose their jobs. All right, the same thing happens with any of these types of addictions. Even someone who may have a non-substance type addiction, someone who's obsessed with a gambling addiction, they start perhaps looking at the internet all the time at the expense of their job. They start looking at the scores of games, and that becomes the obsession. They're thinking more about that than they are about coming up with the best proposal for a new development that their company is trying to go forward with.
How would you differentiate between...
That becomes the primary aspect of their life.
But so how would you differentiate between that kind of addiction and say passion? Say, somebody who's passionate about public service and spends all of his time trying to run the campaign or like being a Mother Teresa, passionate, spending all of her time trying to do a single-minded pursuit of something, or a Steve Jobs who spends all of his time trying to create a product that that the economy will adore. How would you differentiate between addiction and a single-minded, dogged pursuit of one goal towards productive ends?
Again, I think a very good question. I think the biggest difference between an individual who's passionate about what he or she does in life to affect some kind of change, do some good for society, someone who's, even as you said, doggedly, perhaps even single-focused in those means, is that, one, they're doing something that is very beneficial to everyone that they're trying to affect, the people they're trying to help, the corporation they're trying to build into a better corporation, whatever the case may be. Someone like myself, who I find myself to be extraordinarily passionate about what I do. To me, it's a way of life. I feel as though I'm doing something very good. I love what I'm doing. I'm doing something that causes great benefit in someone's life, relieving pain, helping them function better. In other words, the pursuit of which I'm lending myself to is of a higher, noble goal, and it's doing something that helps people around me and is trying to achieve my goal. But that being said, there is a line that even someone who's very passionate can cross where it becomes pathological, where, for instance, you need a certain amount of sleep. If you have someone who may be incredibly passionate, where it becomes to absorb all their life, where it becomes almost an obsessive compulsive type behavior, where they're staying up all night, sleeping 3 hours, and that's all that they're doing to the expense of their well-being. They're losing sleep. Perhaps they're not eating well anymore. They're eating poorly. They're eating fast food all the time. They're neglecting their responsibilities around home and so forth. I would argue that even the individual who may have started out with something that was dogged and passionate for something good can turn into something that can become obsessive, compulsive, addictive, if you will, especially if they find a compulsion to do it and they simply can't stop toning it down. That is an individual who may benefit from some form of therapy to try to curb that type of behavior. So there is a line even between doing something that could be very, very good, but then if it crosses that line, can cause harm, where it's not even doing good anymore.
So just to wrap up this podcast, you mentioned that, and I want to bring the topic back to you for a moment. You mentioned that being a pain physician, you see yourself as serving a higher calling, that it's a noble and honorable pursuit. This pursuit of alleviating pain for individuals, of ameliorating the discomfort in their lives. Can you speak briefly about your motivation and why you see what you do as a means of advancing the public interest?
Sure, I'd love to do that. Well, remember when I first started the podcast, I talked about my early experience when I was 13, where I had my appendix taken out. And again, the pain was not adequately treated. I just remember constantly, it's funny, it was so many years ago, but I still to this day vividly remember constantly calling the nurse, just explaining that it was not adequately treated. I still remember it was like a throbbing, burning type pain around where the abdominal wound was. It took several days for that just to come down. And I just remember what a miserable experience that is. So I think when I think about that experience, it tells me that if I can relieve that kind of suffering in an individual, then to me, I'm doing a very, very noble thing. I mean, at the end of the day, what does a physician do? A physician relieves pain and suffering. Again, I don't want to get into a whole other discussion about end-of-life issues and about longevity, but a lot of medicine in modern times has focused on the issue of maintaining life indefinitely, as long as one can be, maintaining life, sometimes at the expense of quality of life. But I think many of us would agree, including myself, and certainly many of my patients, that it's not just how long we live, but it's rather the quality of life that we can obtain during the time we have this, during the time that we are living. And certainly if we can diminish pain and suffering using safe, effective modalities, then we're enhancing quality of life to a great degree, which I think many people would argue that's perhaps the most important thing in our lives and well-being. So to me, that is of the noblest goals.
Well, thank you so much. This is Dr. Justin Wasserman joining us for episode 17 of Public Interest Podcast, where we interview politicians, activists, advocates, and others who seek to improve the state of the world. According to Dr. Wasserman, alleviating pain and suffering, making life more enjoyable, improving the quality of an individual's life is something that is noble, honorable, and for him defines public service. Thank you so much for joining us. Public Interest Podcast. Look forward to speaking to you next time.